really important that whenever someone is discussing or you're looking into a condition and you're seeing something like a doubling of risk, a tripling of risk, you have to always follow up and say, well, what was the baseline absolute risk? Because that helps quantify what the multiplication fact or factor will be. Welcome back. Today, let's discuss a number of very exciting and hopefully insightful updates in hormone health, specifically thyroid, female hormones, and menopause. And let's jump right in with a few studies on thyroid health specifically. These studies in part help us to better understand if you have Hashimoto's, how at risk are you to then develop hypothyroid? Because these are separate things. Hashimoto's is, yes, the most common cause of hypothyroidism, this thyroid autoimmunity, but understanding what the likelihood of becoming hypothyroid is crucially important because, as I hope these studies will portray, all too often, healthcare providers are, I think, unintentionally, but nevertheless, misleading healthcare consumers to believe that if they have thyroid autoimmunity, let's say Hashimoto's specifically, that their risk of developing true and full hypothyroidism is quite high. And in fact, it's the inverse. And let's go into a few studies that help us to understand this. And with that knowledge, we can intervene at the appropriate level. So the first study attempts to answer the question, what risk factors predict progression from subclinical hypothyroid to hypothyroid? So just as a reminder, SCH or subclinical hypothyroid is a condition wherein your TSH is above the cutoff, so 4.5, but it's not above 10. So you're in this subclinical range between 4.5 and 10 with your TSH, while your free T4 is still in the conventional normal range above 0.8. And you'll also see here, this is from the Tehran study group, and we've reported on data this group published a few years back that found between 9 and 19% of individuals converted from thyroid autoimmunity to hypothyroid. So this is a follow-up analysis from this same group, from the same data set, looking at 270 participants with this mildly elevated TSH, but not true hypothyroid. And so this is really important to look at what happens to this group. What is your risk? A 10-year follow-up was performed. So this is a good range. It's not a short follow-up period where we may miss individuals. And they found 40% became normal thyroid. Yay, this is good news. This should help us be a little bit anchored and not assume that if your TSH is a 5, 6, 7, that you are going to become hypothyroid. Here what we see is 40% remain normal or became normal. 44% remained in that subclinical range, so no progression, also good news. And only 16% developed true hypothyroidism. Now, it's not to diminish hypothyroidism, but it's to help people understand that if you have this mild elevation, we don't necessarily need to intervene very aggressively, aggressive gluten-free dieting, lots of supplements, what have you. We want to be preventative, yes, but also quantify the risk that, in this case, only 16% of this cohort became true hypothyroid. So it's not a guarantee. In fact, like I said a moment ago, the odds are stacked in your favor that you will not become hypothyroid. And a few other factors here that can help us predict your risk. When the TSH was over 10, there was a 5 times increased risk. And a positive TPO antibody led to a 2 times increased risk. So like we've said so many times before on the podcast, we can look at not just positive, negative, but the degree of elevation can be helpful. If your TSH is above 10 and your TPO is positive, this is predictive. Hopefully it helps us strike this balance point of, yes, we want to be preventative. And if there's a family history of hypothyroid, screening for antibodies makes sense. If the antibodies have come back positive, you can take simple preventative measures. But we also want to understand that not every positive carries the same degree of risk. And in this case, the antibodies combined with the TSH help us predict your risk and intervene accordingly. Now, here's another similar but different study examining what percentage of euthyroid or normal TSH and free T4 patients with a TPO positive progress to hypothyroidism while pregnant. And as you may know, pregnancy can be one of the factors that initiates Hashimoto's. And so now we're trying to determine how many of those women then become hypothyroid. So it's a short time window, obviously, but it can be instructive nonetheless. So here, 940 euthyroid women with TPO antibodies were assessed and broken down by those who were given placebo or levothyroxine. 7% progressed to either subclinical hypothyroidism or overt hypothyroidism. And interestingly, the use of levothyroxine did not reduce risk of progression. And as we've said before, and nice sort of carryover of concepts, higher TSH and TPO increased the risk. Just more evidence that should help us look at risk assessment for future hypothyroidism on a gradient. The higher the TSH and the higher the TPO, the higher the risk. Also bearing in mind that your risk in this one study, 7%, in the last study, 16%. So it is something, but I think hopefully refreshing news that your risk is not what I feel it often to be portrayed as 70%, 80%, 90%, more of a, you will likely become hypothyroid, and actually should be restated as you may become, but it's actually unlikely. So what if you do have a mild elevation of your TSH? What can be done naturally? In this study, it was examined whether or not myo-inositol plus selenium can improve this subclinical hypothyroidism. So the mildly elevated TSH, 5, 6, 7, 8, let's say 9. And can the selenium and myo-inositol also improve thyroid antibodies? 148 women with this SCH, subclinical hypothyroidism, or euthyroid, normal thyroid, and positive antibodies were assessed and treated with either myo-inositol or selenium, 600 milligrams of myo-inositol and 83 micrograms of selenium. At 6 months, here's what they saw. TSH went from 5.9 to 4.6. So now you go from over the range to right on the cusp of the normal cutoff of 4.5. TPO decreased and TG decreased. So thyroglobulin decreased by 46 and TPO decreased by 21. Now, just to note that 21 points of TPO reduction, it's not a huge change. And this is why I think it's important to be a little bit bridled with looking at the antibodies, yes, but understanding that the antibodies are not the end-all be-all. The TSH saw what I would consider a notable improvement. The TPO, I mean, is that meaningful? It's hard to say, but I would say that's a fairly minimal movement of the TPO. But importantly, menstrual irregularity also improved, as did fatigue. And this hints at one of the concepts that we continually try to, I guess, embody or share or advocate for, which is treatment of the individual, not of the labs. Depending on your perspective, this may have been a failed intervention. Oh, we only saw a 20-point reduction in the TPO, but Mary, your levels are still 300 or 400 or 500. But if the individual is seeing the TSH move in the right direction, that's a win. If their menstrual regularity has improved, that's a win. And if their fatigue has improved, that's a win. So, like we often say and recommend, this is not an absolute rule, but it applies in many areas. Lab testing should be 1/4 of the data used to inform our thinking and our decision-making. And in this case, that makes a lot of sense. The labs may not have had a huge shift, but if we look at that in the context of the improvements in the symptoms, now we can conclude this intervention, the myo-inositol and the selenium, have been a clinical win. So we want to use labs, but we want to be careful not to fall into this paradigm of treating the labs and not treating the person. And shifting over to gut, which is my most favorite area to intervene, because the impacts of gut care seem to just have such a favorable ripple effect throughout the body. This study is looking at what effect does dysbiosis, imbalances in the gut flora, have on thyroid hormone absorption. This is something that we've published on 2 papers in 2022. This was an observational study in 61 Hashimoto's patients with gastrointestinal symptoms who were taking levothyroxine. Look at this, 39% of these patients tested positive for H. pylori. That's remarkably high. And that H. pylori was associated with requiring a 20% higher dose of T4 and higher antiparietal cell antibodies, which can interfere with the production or alter production of HCl. 83% as compared to 22%. We can take this observational study and tie it in with other interventional studies that have found that treatment of H. pylori or treatment of SIBO or just treatment with something like a probiotic have been shown to reduce the dose of thyroid hormone medication that's been required, ostensibly because it's improving absorption. So really important concept here, the interplay between dysbiosis and thyroid hormone absorption, and to some extent, potentially stomach cell or parietal cell autoimmunity. And we discussed a moment ago the effect of selenium and myo-inositol on Hashimoto's. So this study was looking to see what does selenium status play in a preventative fashion. And in this observational study, 1,200 individuals were followed for 6 years. Now, compared to adequate selenium intake dietarily, low selenium intake was associated with a higher prevalence of TPO antibodies, 10% versus 6. So not a huge change, but something. The prevalence of Hashimoto's, 0.3 versus 0.1. And finally, the risk of developing Hashimoto's was 3.6 times higher. So a couple points here. One, it's hard to parse out if it was the selenium intake in and of itself, or if selenium intake could have been a proxy for people who were eating an overall healthier diet and potentially had a healthier lifestyle, hence this sort of healthy user bias effect that can be challenging to delineate when looking at observational data. And also this note here about relative and absolute risk. Now, depending on how this was framed, someone could say, your chance of Hashimoto's is tripled if your selenium intake is low, which is true, but it's a little bit misleading because your prevalence goes from 0.1% to 0.3%. And this is where we should always be careful to make and draw a distinction between what your relative and absolute risk is. If the absolute risk is low, 0.1, then a tripling of that carries much less of an effect because you're tripling 0.1. Now, if the baseline absolute risk was 15 and that triples, now it becomes 45. So that's a much higher magnitude of a change. So really important that whenever someone is discussing or you're looking into a condition and you're seeing something like a doubling of risk, a tripling of risk, you have to always follow up and say, well, what was the baseline absolute risk? Because that helps quantify what the multiplication fact or factor will be. In another similar study here, what effect does selenium intake have on thyroid function in general? Observational study of 5,500 adults assessed for dietary selenium intake. And interestingly here, selenium intake was not associated with differences in TSH, free T3, and free T4. Now, how do we reconcile these two studies? It's possible that the selenium intake had a slight protective effect against Hashimoto's, like we just discussed, the 0.1 and 0.3. However, remember that there's not a high carryover between Hashimoto's and hypothyroid. So even though there was this protective effect, let's say upstream with the Hashimoto's, the effect size or the magnitude of that effect was so small that it doesn't have, or doesn't seem to have anyway, a impact on your thyroid hormone output as this study delineated. This is why we take a little bit more of a measured approach at the clinic and just with the discussions we have regarding thyroid and antibodies and their predictive value, because the impact of the antibodies in Hashimoto's on thyroid function, hypothyroid, is fairly small. And I hope that comes through here with these two studies. It's something to look at, but we just want to be careful not to overweight how scrupulous we are with the antibody interpretation. Okay, let's go over to menopause. And this was a great study. This is a meta-analysis of 16 clinical trials, 2,100 participants, asking the question, what lifestyle interventions are most helpful for sleep difficulty in menopausal women? Certainly the hot flashing and just the menopausal changes in general, if not overt hot flashing, can interrupt sleep. So what can be done about that? Because obviously anything that helps sleep can be so impactful. And mindfulness or relaxation had a large effect. Low intensity exercise had a large effect. Moderate intensity exercise had a small effect, and CBT or cognitive behavioral therapy had a small effect. So just a reminder to at least be low intensity exercising and performing some mindfulness, breath work, relaxation, and this can help improve your sleep quality. So simple lifestyle interventions that can really move the needle. And what about herbal interventions? In this case, looking at a meta-analysis of 15 randomized control trials on the impact of ginseng, an adaptogenic herb, for improving menopausal symptoms. So remember, this being a meta-analysis of randomized control trials, we have a placebo and interventional ginseng groups. Ginseng led to overall improvements in menopausal symptoms with a small effect size, hot flashes, small effect size, and quality of life, small effect size. Two things here to take away. The last study found large effect size with relaxation and with low intensity exercise. This study is finding a small effect size from a supplemental intervention of ginseng. Important to keep this in mind because I think all too often we as healthcare consumers, and I include myself in this, can fall into the erroneous thinking that supplements are more powerful than lifestyle, especially if you've been reading a lot in the blogosphere about health. Oh, my adrenals and my HPA excess, and this is why I can't sleep. That may be true mechanistically, but it doesn't mean that just because ginseng is offered up as an intervention to help with the HPA excess or with the adrenals, that it's going to be the most powerful. And this is why at the clinic, we really advocate for, and in Healthy Gut, Healthy You, I advocate for this approach of the diet, lifestyle, and gut health foundations model. And then we consider supplementation. And it's really important to kind of keep this hierarchy in mind so that we do the most foundational things first, and then we can consider layering on top of that things like ginseng. Okay, and what about PCOS, polycystic ovarian syndrome? This next study wanted to better understand, do heavy metals increase the risk for PCOS? Observational data, 370 women with PCOS, 440 healthy controls, all tested for heavy metals in the blood. And look at this. Compared to healthy controls, PCOS risk was increased with higher arsenic, 2.5%, lead, 1.8%, and barium, 1.2%. So, something to consider if you have PCOS. One caveat is some labs are using somewhat arbitrarily determined reference ranges for what's normal and what's abnormal. We are using CDC guidelines at the clinic, and a big thank you to Dr. Joe Mather for doing the hard work of pulling out all those numbers for our clinical team so as to not have to use the reference ranges that have been put forth by some of the labs, which may be more so from a small in-house study that some of these labs have done. And some labs have had litigation brought against them for using ranges that were not really substantiated. They may be using a provocation agent like DMSA or EDTA to flush toxins out and interpreting those levels in the reference ranges for non-provoked urine, and this will make everyone look positive. So we want to be careful not to fall into the, well, geez, everyone I test is positive, because if that happens, and this is what happened to me early in my career, we should take pause and say, if everyone is positive here, then this test must be suffering from a real lack of specificity and suffer from a high false positive rate. I don't believe that was the case here, and it's really important that you as a healthcare consumer make sure your clinician is going to be cautious, again, because unfortunately with sort of functional and integrative healthcare lab testing, oftentimes the progressive ranges haven't been fully flushed out, and it can lead to nearly everyone coming back positive, and then everyone gets treatment, and then guess what? The response rate to that treatment becomes very, very low. And coming over to magnesium and what impact magnesium has on PCOS, this next trial was a randomized control trial of 64 women with PCOS who were given placebo or magnesium oxide. Not necessarily the most absorbable form of magnesium, but nonetheless, look at this. Magnesium led to improved energy, emotional well-being, and quality of life with no changes in hormonal symptoms like acne, hair loss, or menstrual irregularity. So that is the rundown on some new studies in thyroid, and hopefully those help you better understand your risk and what sort of predictive validity Hashimoto's antibodies have for becoming true hypothyroid, and also what merit selenium and myoinositol have, and also looking at some simple lifestyle and herbal interventions for menopause and a few others for PCOS, polycystic ovarian syndrome. Okay, this is Dr. Michael Ruscio, and I'll talk to you next time.